Welcome back to the deep dive. Today, we are pulling back the curtain on something that happens millions of times a day in healthcare.
A calculation, really.
Exactly, a calculation. Specifically, how doctors figure out drug dosages based on kidney function.
And for most people, that probably sounds like, just routine math.
Right. But we're looking at situations where the stakes could not be higher. We're talking about drugs with a very narrow therapeutic index.
Where the line between an effective dose and a toxic, even life-threatening dose is razor thin.
And an inaccurate measure of how well your kidneys are working can lead to, well, devastating overdosing.
Or, on the flip side, dangerous underdosing that makes a treatment completely useless.
So today, we're diving deep into the limitations of the standard markers for kidney function creatinine clearance, or CRCL, and estimated GFR, eGFR. Our mission is to really unpack why these core tools are imperfect, where the formulas break down for certain people, and what that means for patient safety.
It's a huge deal.
Okay, let's unpack this.
To really get it, you have to start with the molecule itself, creatinine.
Okay.
If you don't understand the physical limitations of creatinine, you can't understand why the results can be so unreliable.
So what is the fundamental problem?
The fundamental problem is that creatinine is an imperfect proxy for kidney function. Its production, its elimination. It's all tied to so much more than just your kidney health.
How so?
Well, creatinine is a waste product. It's generated from the breakdown of creatine phosphate in your skeletal muscle.
In your muscles?
Which means the amount of it in your blood, your serum creatinine, is directly dependent on how much muscle you have.
So if you have low muscle mass...
You produce less creatinine. Simple as that.
So we have a marker that's supposed to tell us about the kidney's filtering capacity, but its starting point, its baseline, is dictated by all these non-kidney factors.
Exactly. Age, sex, muscle mass, even your diet.
So a naturally low creatinine level could actually give a dangerously false sense of security.
It absolutely can.
And
it does, especially in older or more frail patients.
Can you give me an example?
Sure. Think of an 85-year-old woman with significant muscle wasting.
Okay.
Her creatinine level might look perfectly normal. On paper, it suggests her kidneys are fine. But in reality, her GFR, her actual filtration rate, could be dramatically impaired.
So the low production of creatinine is masking a high level of kidney damage.
It's hidden kidney disease. And that poses a huge risk when you're dosing high-risk drugs.
And beyond just how it's made, there's also an issue with how the kidneys actually get rid of it, right? That adds another layer of error.
That's right. When we calculate creatinine clearance, the CRCL, using a formula like Cockcroft-Gault, we're trying to estimate the glomerular filtration rate, the GFR.
The main filtering job?
Yes. But creatinine isn't just eliminated through that filtration. A pretty big chunk of it is also actively pushed out through a process called tubular secretion.
So it's living through two different pathways.
And because the CRCL calculation basically counts both of those pathways, it inherently and systematically overestimates the actual GFR.
So the number we get is often an inflated version of the truth.
It is.
What's fascinating here is that I gather this error isn't static. It actually changes depending on how sick the patient is.
That's correct. The degree of that overestimation, it gets larger as the patient's true kidney function declines.
Why is that?
When kidney function is already moderately or severely impaired, that tubular secretion pathway becomes a proportionally larger contributor to getting rid of the creatinine.
So, ironically, just when you need the most accuracy for a critical dosing decision.
The calculation is at its most inaccurate. It widens that error gap significantly.
And what about acute situations? If a patient has an acute kidney injury, an AKI, their function can plummet really fast. Can serum creatinine even keep up?
No, it can't. Not at all. And that introduces the problem of a time lag.
A delay.
A critical delay. Serum creatinine levels do not reflect real-time kidney function in those rapidly changing situations.
Yeah.
Creatinine takes time to build up in the blood after an injury.
So you could be making a dosing decision for a powerful antibiotic based on a lab result that's, what, hours old?
Hours, sometimes a full day behind the patient's actual status.
Yeah.
It's a critical flaw during a medical crisis.
Okay, so to sum up this first part, the input signal, creatinine, is flawed. It's influenced by muscle, by diet, and the calculation itself overestimates GFR, especially when a patient is at their sickest.
That's the core of it.
So now let's turn to the math. Here's where it gets really interesting, because the formulas built around creatinine introduce their own profound and sometimes arbitrary inaccuracies.
They really do, especially when you apply them across a diverse population.
Let's start with older adults again, but from the formula perspective.
Yeah.
Why do CRCL formulas so often fail seniors?
It comes right back to that muscle mass issue, which the formulas just don't correct for properly.
So it's the same problem, but now it's baked into the math.
Exactly. Since older patients have less muscle, they produce less creatinine. The standard formulas often lead to a significant overestimation of GFR in this population.
And the consequences.
If a formula tells you a dose is safe, based on a GFR of, say, 50, but their true GFR is actually 35, you're pushing them towards toxicity.
That's a massive issue, especially since older adults are so often on multiple medications.
It just magnifies the consequences.
And speaking of systemic issues, let's talk about that infamous sex factor in the Cockcroft-Gault formula. The C&G calculation literally multiplies the result by 0.85 for females.
Yeah, it's a systemic bias based on a generalized assumption.
The assumption being that women have less muscle than men.
Right. And while that might be true on a population average, clinical medicine is about the individual patient in front of you.
So it fails at the individual level.
It can fail spectacularly.
Yeah.
Think about two extremes, a highly muscular female athlete and a very frail elderly male patient.
Okay.
The formula applies that 0.85 reduction to the female athlete, potentially underdosing her based on a false assumption.
And for the frail male?
Conversely, it might give him a high clearance number, exposing him to a serious overdose risk. The formula just treats sex as a binary proxy for muscle mass, and that fails the individual every time.
That's a huge insight. The danger isn't that the math is complicated, it's that it's relying on these broad assumptions that just might not be true for the person you're trying to treat.
Precisely. And the calculation chaos doesn't stop there.
Oh.
The C&G formula also requires body weight.
Hmm.
But which weight? This is where prescribers really get tripped up.
Explain the weight variations. Why are there different options? Actual, ideal, adjusted.
It really depends on the medication and the patient. For very obese patients, for instance, using their actual body weight can grossly overestimate their kidney function.
Leading to an overdose.
But potentially, yes.
Yeah.
So clinicians often use ideal body weight, or IBW, instead. The argument is that kidney clearance doesn't just keep increasing indefinitely with more fatty tissue.
But that's also an assumption, isn't it?
It is, and it's also imperfect. Some drugs that are highly fat-soluble, they do distribute into that fatty tissue, so their dosing really is tied to actual body weight.
So if a clinician uses the wrong way, say ideal weight, when they should have used actual...
They could end up inappropriately underdosing a critical medication. It's a complex choice the prescriber has to make, drug by drug. It's not a number the lab just gives you.
And the compounding problem here is formula discordance. If you have 3 different formulas, C&G, MDRD, CKD, EPI,
Then they give you 3 different estimates for the same patient.
which results in 3 different dosing recommendations, how does a clinician move forward with that?
That discordance just highlights the fragility of relying on a single number. A patient might have an eGFR of 58 from one method, which is just above a critical threshold, but
Yeah.
their CRCL calculated with C&G might be 45, which is well into the range that requires a major dose reduction.
So the clinician is forced to choose which number to trust.
And that choice can literally mean the difference between a treatment working and severe toxicity.
So if we connect all of this to the bigger picture, the flaws in the marker and the flaws in the math become genuinely dangerous when we talk about those drugs with a narrow therapeutic index.
This is the high-stakes table. We're talking about critical chemotherapy agents like carboplatin, immunosuppressants, even some common heart medications.
Where being off by even a little bit has huge consequences.
If your estimated kidney function is off by just 15 or 20 LMN, you're directly risking that patient's life. You might give a subtherapeutic antibiotic dose, letting an infection rage,
Or a toxic dose of a cancer drug.
causing life-threatening complications. It's that serious.
And this is where we hit a systemic roadblock that I find truly baffling. The metric mismatch. Most of the older established drug dosing recommendations are based on CRCL from Cockcroft-Gault's.
That's right.
But modern hospital labs, they typically report estimated GFR or eGFR from newer formulas like CKD-EPI. Why are these not interchangeable?
This is a source of frequent, dangerous error, and it all centers on one word: normalization.
Normalization.
The eGFR value from the lab is almost always normalized. It's adjusted to a standard body surface area, about 1.73 square meters. It's telling you the kidney efficiency for a standardized average person.
Okay, an average person. But CRCL.
CRCL is generally not normalized. It gives you the total clearance capacity for for that individual patient's actual body size.
I think I see. So if I'm a person who is much larger than average,
Your normalized eGFR might look okay, but your actual total clearance, the capacity you need to flush out the drug, is much higher.
and if I use that normalized eGFR number for dosing,
You're effectively underdosing yourself. The calculation is artificially minimizing your real clearance capacity.
wow. And is the opposite true for someone who is much smaller?
Precisely. If you're significantly smaller or frail, the error runs the other way and you risk an overdose.
So the drug manual is asking for the size of the whole filtration tank, which is CRCL.
But the lab is giving you the filtration efficiency per square inch, which is the normalized
Mm.
eGFR. You just cannot mix those metrics for these high-stakes drugs.
And our sources show this mismatch is a known safety hazard.
A huge one. It increases the risk of adverse events, like bleeding with certain anticoagulants, if the wrong metric gets used.
It just sounds like a prescription for prescriber challenges. You have imperfect data, competing formulas, and a lab result that often doesn't even match what the drug manual is asking for.
That's the daily reality.
What are the key barriers that physicians face in the moment?
Well, first, we see a lack of adherence. Studies consistently show that physicians often don't adjust dosages appropriately, even with documented renal impairment.
Why not? Is it just workload?
That's part of it. Workload, cognitive fatigue, or sometimes just underestimating the significance of, say, mild or intermediate impairment.
So they see an eGFR of 55 and think it's not renal failure and just move on.
Right, they skip the adjustment, even though that level absolutely requires modification for many high-risk drugs.
What else?
Second, there's a lack of clear data. Prescribers struggle because a lot of drug information sources still don't have specific validated dosing recommendations based on eGFR,
So the guidance is still tied to the older CRCL calculations.
which leaves the clinician to do this complicated, often unvalidated conversion on their own in the middle of a busy day.
And finally, the technology we rely on isn't necessarily helping here.
No, it can introduce its own errors.
How?
Computerized order entry systems might not automatically or correctly factor in those crucial patient-specific parameters like distinguishing between actual ideal or adjusted body weight.
So the computer might just default to the wrong one.
Exactly. If the default is actual weight for an extremely obese patient where ideal weight is needed, the system can spit out a dangerously overestimated dose recommendation.
The clinician has to have the presence of mind to catch that and override the system.
It's every single time.
So what does this all mean for patient safety? We've established that just relying on a single number or an automated calculation is inherently risky.
Very.
What are the essential best practices that shift the focus from data entry to, comprehensive clinical judgment?
The first rule is caution and context. If you take one thing away, it's this. You have to use extreme caution when you interpret a single eGFR value.
Especially when that number is close to a critical threshold.
Yes, like that 60 mmol mark.
Yeah.
That boundary often dictates whether a dose needs adjustment or not. If you're near it, you need more information.
You have to treat the human, not just the lab report. So what does putting the numbers in context really mean?
It means looking at the whole clinical picture. What's the patient's recent history? Are they dehydrated? Have they been on a high-protein diet? Do they have significant muscle wasting?
All those things that affect creatinine in the first place.
Exactly. Those factors let you understand if the eGFR is a true reflection of their baseline renal function, or if it's just temporarily off because of something else. A number in isolation is a guess.
But a number framed by clinical history is valuable information.
That's it.
And since we know a single snapshot is so faulty, what about tracking the patient over time?
Trend analysis is paramount. Never, ever fixate on one isolated result.
Look at the trajectory.
Look at the trajectory of an individual's eGFR over time. And crucially, you have to make sure you're using the same estimating equation consistently.
Because switching between formulas would make the trend meaningless.
Completely meaningless. It would just be formulaic noise. Consistent measurement lets you spot a genuine decline.
And what about the administrative side? The procedural checks. What must prescribers do with guidelines and resources?
They have to adhere rigorously to established country-specific drug dosing guidelines and manufacturer recommendations.
And reading the fine print.
You have to read the fine print. When you're using a drug with a narrow therapeutic index, you must actively verify that you are using the correct metric, CRCL or eGFR, and the exact formula specified for that drug.
So if the manual demands a C&G calculation,
You must perform that calculation,
No.
even if the lab only gave you the CKD EPI estimate. You have to do the extra work.
Finally, we have to acknowledge this isn't a solo effort. The complexity here seems to demand specialized knowledge.
Absolutely. The pharmacist is the essential safety net in this whole process.
So leverage their expertise.
We must leverage the expertise of hospital and clinical pharmacists. They are trained to navigate these nuances of renal dosing, formula conversions, and drug interaction risks. Utilizing them is the final, crucial step to prevent these kinds of problems.
This deep dive has really shown us that the tools we rely on to assess kidney function are, well, fundamentally flawed.
They have inherent limitations, for sure.
From the physiological quirks of creatinine to the mathematical risks in the formulas, the journey from a patient's muscle tissue to that final drug dose is just filled with potential missteps.
Muscle mass interference, formula discordance, metric mismatch.
And relying too heavily on an automated lab result without applying that careful, context-driven clinical judgment can have devastating consequences.
Especially with high-risk medications.
So here is something to consider. Given the inherent physiological inaccuracies of creatinine, influenced by muscle mass, age, and diet, and the known discordance between standard formulas like Cockcroft-Gault and CKD-EPI, how crucial is continuous trend analysis, that consistent tracking of a patient's renal function over time to genuinely safeguard a patient's health, compared to relying on a single, isolated lab result when administering those high-stakes medications? The answer puts the onus squarely back on clinical vigilance over simple calculation. Thank you for joining us for the deep dive. We'll see you next time.